Right. So a very, very warm good evening to all our respected doctors present on this platform. My name is Manu Sugan. I am from Future Mankind, and I warmly welcome all of you on today's live talk, which is care and which is cardiac and renal complications in pregnancy. So, before we start the discussion, I would just like to take you through a very brief introduction of about our organization. So, Mankind Pharma has completed 25 years of professional journey as it started in 1995 by our chairman, Mr. R.C. Juneja. And the company was started with the vision that we want to become the most admired Indian pharma company. In the pursuance of such efforts, I am very pleased to mention that Mankind Pharma is now become number one company in terms of the prescription, number fourth company in terms of the turnover. We have a global presence in 34 countries, and we have total 19 manufacturing unit, including USFD and WHO compliant manufacturing unit. Because we are serving life and we live up to our values and our names, Mankind, we truly want to salute our true heroes of mankind, which are our medical fraternity only and which are our doctors only, because they were the only hope during the crisis for the people, right? So Mankind Pharma has actively contributed to PM Cares Fund, and all the employees of the Mankind Pharma donated 1 day salary to the PM Care Fund just to facilitate the procurement of protective gears for our frontline managers and frontline warriors. I am very pleased to mention that we have paid a token of respect in terms of amount 100 rupees crores to those who have made the supreme sacrifice for the nation. This include the families of martyred doctors, families of martyred policemen, and the families of paramedical staffs. So because we are committed to serving the life, and we still are in touch with our vision that we want to become most admired pharma company. Mankind Pharma is also inclined towards the innovation and technology, and we are pleased to announce that we have developed a new antidiabetic entity into our R&D center, which is GPR 119, and we announced the global patent of this molecule, which is valid till 2037. So, with this, it's a time to introduce the most precious and important guest of our evening about our speaker. So, I will hand over the session to Dr. Prashant, who will be introducing our speaker. Thank you.
Thank you, Manu, and a very warm welcome to everyone who has joined us here to today's evening with this educational program, The Care, which is cardiac and renal complications in pregnancy. Now, let me introduce you to our speaker of this evening. Although Padma Shri Dr. Kamini Rao doesn't need any introduction, still few lines I would like to mention about her. She is founder and medical director of Milan, which is the prime institute for the infertility management. She is chairperson of the International Institute for Training and Research in Reproductive Health and recipient of Padma Shri Award by Government of India for the recognition of distinguished services in the field of reproductive medicine on 26 April 2014. She has been national icon and awarded by APS Research and Media for India's most trusted IVF treatment center of the year in 2018 and 19. She has been recipient of more than 30 awards and grants at various national and international level conferences. Her show, Dr. Kamini Rao's Masterclass, is a massive success amongst the viewers and not just across India but globally. So, without taking any further time, I hand over this session to Dr. Kamini Rao. Ma'am, over to you.
Thank you very much, Mankind, for giving me the opportunity to speak on a very important subject, and that is on cardiometabolic as well as renal complications that occur in pregnancy. And Mankind, of course, has always been in the forefront of research as well as of producing very ethically and quality drugs and looking after patients, as well as in very troubled times like the COVID times. They've also been donating a lot for the benefit of our doctor heroes, warriors, as he called, in these troubled times. So, without much ado, let's go and look at these very important topic, that is cardiometabolic and renal complications. It is a very vast topic, I must tell you, and therefore I must start from the very beginning. Okay, and first and foremost, let's just understand the basics. Why are we putting a stress on pregnancy and renal disease and pregnancy and cardiometabolic disease? Because pregnancy itself is a stress test for the cardiometabolic conditions, and for women identifying at risk during and after pregnancy, because there is always a lot of physiological changes that occur in pregnancy that can unmask any subclinical conditions such as diabetes and hypertension. So, if it is subclinical, then it gets unmasked during pregnancies. So, to understand the metabolic changes in normal pregnancy, one has to look at the basic glucose metabolism. The hyperplasia of the pancreatic beta cells increases the insulin secretion, and therefore there is an initial rise of insulin sensitivity. Progressive insulin resistance occurs, and the pancreatic function may not be sufficient to overcome this insulin resistance, and therefore gestational diabetes occurs. Now, with the glucose metabolism, one must understand that the fasting glucose levels in pregnancy is lower due to an increased glycogen storage and, of course, increased peripheral utilization of glucose consumption by the fetus, because there is two people to use that glucose, and of course a decreased glucose production by the liver. This relative hypoglycemia allows the mother to preferentially use fat as a fuel and preserve the glucose and amino acids for fetal metabolism. And therefore, when you're looking at the lipid metabolism, the total cholesterol that we have, that is the high density and low density lipoprotein particles, the triglyceride levels beginning early in pregnancy, reaching peak levels towards the second trimester, and that increases, and towards the end of pregnancy the maternal fat consumption increases and storage declines due to the increased lipolytic activity and decreased lipoprotein lipase activity. Therefore, the maternal hypertriglyceridemia leads to fetal growth and development, energy depot for maternal lactation. Which means you will see a macrosomia in the baby, and that's why we say that in hyperglycemia, babies that are about 4 kilos at birth and are more prone to a hypoglycemia after birth, and are more prone to a hypoglycemia after birth, and of course more prone for operative deliveries. What happens to the plasma volume during pregnancy, which is extremely important? It increases as much as almost 50% more than normal, which means that plasma volume and red cell mass expand as early as 8th week and peaks around the 30th week, which means that there could be a hemodilution and a physiological anemia, which one must understand, and therefore the need to supplement iron in these situations. At term, the total plasma volume gain is around 1000 to 1500 ml, is about 50% above the baseline. Greater increase in intravascular volume compared to the red cell mass leads to dilutional anemia, as I have told you, of pregnancy. This is the most apparent at 30, 34 weeks, and one must not think that this is going to be anemia due to blood loss. It is only because of the dilution of the plasma, which is almost 50% more. So, increasing this now, we must also look at this hemodynamic changes that sodium and water retention occurs. You must have also known that because of the increase in the size of the baby, the amniotic fluid, you'll also find edema of the lower limbs, and this volume expansion is associated with sodium and water retention, and about 1,000 milliequivalents of sodium and 6 liters of water are retained and distributed among amniotic fluid, fetus, and intra and extracellular spaces. So then what happens as a result of this is that the increase in cardiac output, which can be as high as 50% above the baseline during the entire pregnancy, half of this change occurs by the week 8, and this is so early in pregnancy, incited by increase in blood volume, reduction in afterload, decline in systemic vascular resistance, and rise in maternal heart rate. So, as a result, in this vascular resistance increase, there is a decrease due to the high flow, low resistance circuit in the uteroplacental circulation. Why? Because of the vasodilation, decreased sensitivity to the norepinephrine and the angiotensin, increase in the nitric oxide and the prostacyclin production, and reduction in aortic stiffness. There is an increase in plasma renin activity, decrease in atrial natriuretic peptide. So, keeping all this in mind, there is an increase in the uterine blood flow, allows perfusion of the intervillous spaces of the placenta, and support fetal growth. As a result, the trophoblasts of the placenta invade the spiral uterine arteries. Vascular smooth muscle cells are lost and replaced by fibrinoid material, turning them into large dilated blood vessels like lakes, increased perfusion to the placenta. This, of course, then leads to even changes in the aorta, fragmentation of reticular fibers, decrease in acid mucopolysaccharides, loss of normal corrugation of elastic fibers, and hypertrophy and hyperplasia of the smooth muscle cells. So, as a result of this, there must be some amount of coagulation system disturbances. Of course, there is, as a result of which there's increased plasma level factors of 7, 8, 9, 10, and 12, von Willebrand and fibrinogen. Of course, there is a decrease in the protein S levels, a decrease in anticoagulant response to activated protein C, and blood volume increases, venous stasis occurs, and capacitance vessels dilate, and venous return decreases due to the pressure from the gravid uterus on the inferior vena cava. What happens next is a hypercoagulable state, 20% reduction in prothrombin, and a partial thromboplastin time. So, this is important for us to understand that this is a hypercoagulable state. So, give it to understand, we have to understand that the often insidious represents one of the most common complications of pregnancy, affects 5 to 10% of all pregnant women, classified into 4 categories. That is, there could be chronic hypertension, that is, hypertension prior to getting pregnant, a gestational or a pregnancy induced hypertension which comes during pregnancy, preeclampsia, and eclampsia superimposed on chronic hypertension. So, this is something we need to look at. So, what would be the risk factors for hypertensive disorders of pregnancy? Let's just look at starting from just maternal age, obesity, the race, nulliparity because of the first birth. So, if you have your first pregnancy very late in your maternal age, the chance of you having hypertension is much higher, and that is common sense. Then, multiple births, family history of preeclampsia, underlying medical conditions such as diabetes, chronic hypertension, and the presence of antiphospholipid antibodies. Chronic hypertension, which predates pregnancy, and gestational or pregnancy induced hypertension, is isolated increase in blood pressure that usually manifests after 20 weeks gestation. Preeclampsia is hypertension associated with thrombocytopenia, impaired liver function, new onset renal insufficiency, pulmonary edema, and new onset cerebral or visual disturbance. Traditionally, however, the presence of proteinuria was required for the diagnosis of preeclampsia. However, this criterion was eliminated by the American College of Gynecologists and Obstetricians in 2013. So now diagnosing hypertension disorders of pregnancy, if chronic hypertension is diagnosed, a blood pressure of 140 by 90 millimeters of mercury diagnosed before pregnancy or before 20 weeks of gestation, preeclampsia, development of hypertension at 20 weeks of gestation associated with either proteinuria or signs of systemic disease, elevated transaminases, thrombocytopenia, visual disturbances, renal insufficiency, or pulmonary edema. Preeclampsia can progress to eclampsia, which is marked by grand mal seizures. Proteinuria during pregnancy of more than 300 milligram protein per 24 hours urine, and urine dipsticks unreliable, not used during pregnancy to diagnose proteinuria. Let's look at a case now. A 32-year-old woman whose gravida 1 para 0, history of chronic hypertension and type 2 diabetes, presented at 35 weeks gestation with a blood pressure of 180 by 100 millimeters of mercury. Had an emergent surgical delivery, remained hypertensive after delivery despite antihypertensive therapy. Serum creatinine level in hospital 2.6 milligrams per deciliter. 2.6 milligrams per deciliter and hemoglobin of 9.3 milligrams per deciliter, platelet count of 92 into 10 to the power of 3 microliters, and 1 month prior, and platelet count was 160 into 10 to the power of 3 microliters, and no proteinuria and hematuria. Renal ultrasound, normal sized kidney, and no signs of chronic kidney disease. Now, my dear friends, what is your likely diagnosis? Preeclampsia, early onset before 34 weeks or late onset after 34 weeks of gestation. Early onset preeclampsia, the more severe form, peripheral resistance decreased cardiac output leading to fetal uterine growth restriction. Late onset preeclampsia, decreased peripheral resistance, increased cardiac output. Now, the risk factors for preeclampsia is extremely important. The positive risk factors are family history of preeclampsia, nulliparity, multiple pregnancy, advanced maternal age, in vitro fertilization, maternal comorbidities like diabetes, chronic hypertension, obesity, chronic kidney disease, and history of SLE, and previous placental abruption or intrauterine fetal growth restriction, abnormalities of trisomy 13, and molar pregnancies. The negative risk factors are maternal smoking and prolonged sexual cohabitation. Let us look at the pathogenesis. This is a busy slide. However, let's just go through it a little slowly. Pathogenesis of preeclampsia. One is, of course, the genetic factors that you see here, the FLT1 and the SNPs and the trisomy 13, and of course pre-existing risk factors of chronic hypertension, diabetes, and antiphospholipid antibodies, and the immunological factors, the NK cells and the T cells imbalance. All that goes across to a shallow placentation, and then to reduced placental perfusion, and of course leads to the oxidative stress in the endometrium. So this is the stage one, and the second trimesters, that is the first and second trimesters. This lays the foundation for the intrauterine growth restriction. Now you do the it increases the circulating split FLT1, and of course the SENG, and decrease circulating PIGF and the VGEF. Other factors, example, obesity, pro-inflammatory factors, and of course the AT1 autoantibodies. This appears in the stage 2 or the third trimester. This results in a systemic vascular dysfunction, a capillary leak, and vasospasm. However, the genetic factors can also directly come into this particular stage. So one can understand that it is important for us that it may not go through all these stages. The genetic factors can come directly into the systemic vascular dysfunction. From here, you will see proteinuria, glomeruloendotheliosis, a coagulation abnormalities with the HELP syndrome, and of course, you will see the angiotensin 2 sensitivity and hypertension. So, this will be our pathogenesis for the preeclampsia. Now, how do you manage preeclampsia? Only definitive treatment, delivery of the fetus is very important. Work in progress on novel therapies important. Preconception counseling and perinatal BP control, management of complications, timely delivery of the fetus, and postpartum surveillance. This would be the summary of how you will actually look at it. But for women with preeclampsia without severe features at 30, less than 37 weeks of pregnancy, and expectant management should be provided. After 37 weeks, delivery rather than observation should be considered. So it's important for us to understand that the women with preeclampsia with severe features at or after 34 weeks, or in those with unstable maternal or fetal conditions, irrespective of the gestational age, maternal stabilization and delivery should be considered. Women with preeclampsia with severe features at less than 34 weeks, otherwise stable corticosteroids to promote fetal lung maturity and to continue the pregnancy. Eclampsia and preeclampsia with severe features, parental magnesium sulfate with continuation intraoperatively and postpartum for women undergoing cesarean section. Very important. And looking forward, let's look at even a case one continued: severe hypertension and at least one of the fetuses. Just 1 minute. Yes. So, severe hypertension and at least one of the features of severe preeclampsia and the platelet count of 92 lakhs. Serum creatinine was also elevated, but there was no baseline for comparison, no proteinuria. Patient would need a calcium channel blocker for BP control. Now, what postpartum surveillance for women with gestational hypertension or preeclampsia must receive discharge instructions including information about the signs and symptoms of preeclampsia. Postpartum hypertension and postpartum preeclampsia are more common than previously thought. Affected women have angiogenic profiles that are similar to women with preeclampsia and therefore may represent a group with subclinical or unresolved preeclampsia. So, gestational hypertension, which is systolic of more than 140 millimeters of mercury or a diastolic of more than 90 millimeters of mercury, or both, on two occasions at least 4 hours apart, after 20 weeks of gestation in a woman with a previously normal blood pressure, and severe when the systolic reaches 160 and the diastolic reaches over 110. We must be very careful. Gestational hypertension occurs when hypertension without proteinuria or severe features develops after 20 weeks of gestation and BP returns to normal in the postpartum period. Outcomes in women with gestational hypertension usually are good. Gestational hypertension is associated with adverse pregnancy outcomes and may not represent a separate entity from preeclampsia. So, management of gestational hypertension and that of preeclampsia without severe features is similar in several aspects and both require increased surveillance. So, women with gestational hypertension who present with severe range blood pressures should be managed with the same approach as for women with severe eclampsia. Gestational hypertension and preeclampsia may be undistinguishable in terms of long term cardiovascular risks, including chronic hypertension. So, if we are to look at antihypertensive agents for urgent BP control, we have in our box a labetalol, a hydralazine, and a calcium channel blocker, and that is nifedipine. So, if we were to look at the kind of dosages that we give, with labetalol, we look at 10 to 20 milligrams IV, and of course then 20 to 80 milligrams every 10 to 30 minutes to a maximum cumulative dosage of 300 milligrams or constant infusion of 1 to 2 milligrams per minute IV. The other is, of course, hydralazine, 5 milligrams IV or IM, and then about 5 to 10 milligrams IV every 20 to 40 minutes to a maximum cumulative dosage of 20 milligrams or constant infusion of zero point 0.5 to 10 milligrams per hour. Nifedipine is actually about 10 to 20 milligrams orally, which is sublingual. Repeat in about 20 minutes if required, and then 10 to 20 milligrams every 2 to 6 hourly to a maximum dose about 180 milligrams. Of course, nothing goes without complications or any kind of adverse effects. With labetalol, you have tachycardia and, of course, lesser adverse effects, and therefore that would be a drug of choice for pregnancy-induced hypertension. It can be avoided in patients with asthma and pre-existing myocardial disease and decompensated cardiac function, heart block, and bradycardia. However, with hydralazine, one has to be very careful of maternal hypotension, headaches, and abnormal fetal heart rate tracings. The other is, of course, with nifedipine, you may observe frequently headaches and reflex tachycardia. So, one thing we must understand that having finished with our hypertension, let's look at the gestational diabetes mellitus. Gestational diabetes mellitus is again something that we will have to understand with the lifestyle problem that we have today. We are seeing increasingly the obesity that has come up as a kind of problem of this century. We have to actually fight with this diabetes because of the obesity as well. So it's called diabetes. So, with this gestational diabetes, defined as glucose intolerance with onset or first recognition during pregnancy, gestational diabetes mellitus is commonly asymptomatic. GDM confers a risk for significant complications during the peripartum period, including increased likelihood for cesarean and preeclampsia, as well as increased neonatal morbidity like macrosomia, hypoglycemia, and jaundice and mortality. Women with histories of GDM had more than a seven-fold increased risk of developing type 2 diabetes within 5 to 10 years. The risk factors for GDM would be a BMI of over 25, maternal age of 25 years or older, the Asian Pacific Islander, Native American, Hispanics, and the Black race, family history of diabetes, overweight, or obesity, previous pregnancies with newborn birth weights of over 9 pounds or greater, and a history of a random plasma glucose level of more than 126 milligrams per 100 ml, and glycosuria. So, the mechanisms underlying the insulin resistance I've even explained in my previous slide as well for GDM. The advanced maternal age and the overweight, obesity, a Western diet, all the crap food, ethnicity, the intrauterine environment, hypertension, and all this is very this thing as a precursor for the diabetes mellitus. The chronic low-grade inflammation, the IRS1 phosphorylation defects, insulin receptor phosphorylation defects, hyperleptemia, adiponectin, and the PPAR-Y, and the adipocyte fatty acid binding protein. The important thing here is the beta cell dysfunction, insufficient insulin production, and therefore one has insulin resistance and hyperinsulinemia. And going here below, you will see that there is an increase of glucose and free fatty acids. Look at the pregnancy. You will have the thing of the placental lactogen, estrogen, progesterone, cortisol, and prolactin increase. A defective insulin receptor phosphorylation is something which one has to be looking at, and decreased pancreatic beta cell mass, increased insulin expression, increased glucose stimulated insulin secretion, again leading to hyperinsulinemia. So these are some of the reasons why we are going through with the mechanisms for insulin resistance. Okay, so case 2. A 30-year-old woman in her second pregnancy has had one live birth and no abortions. She presents for prenatal care at 24 weeks gestation. Her weight is 220 pounds and a BP of 130 by 80 millimeters of mercury. Uterine size is appropriate for gestational age and a family history of a mother who has type 2 diabetes mellitus. Urine dipsticks shows 3 plus glycosuria and negative for ketones. My question is, what tests should be done to evaluate glucose tolerance, and how is the diagnosis of gestational diabetes mellitus established? So, let's look at the diagnosis for diabetes, gestational diabetes. All women with diabetes risk factors be screened for undiagnosed type 2 diabetes at their initial prenatal visit. Universal screening for diabetes at 24 to 28 weeks gestation. Testing used to diagnose type 2 diabetes in non pregnant individuals. That is, a fasting blood glucose followed by a 75-gram glucose load and a 2-hour plasma glucose measurement could be used for early pregnancy screening. ADA endorses a universal one-step 75 grams OGTT without a challenge test that precedes it. Patient presents with severe risk factors of GDM. Age is over 25 years, obese family history of type 2 diabetes. Patient's capillary glucose reading was 190 milligrams per deciliter. Fasting glucose next morning was 140 milligrams per deciliter, and the diagnosis of gestational diabetes was made. Patient started on dietary and insulin therapy. The management of GDM, the American Dietary Association recommended targets for women with type 1 or type 2 diabetes is a fasting glucose of 70 to 95 milligrams per 100 ml or 3.9 to 5.3 millimoles per liter, and either 1 hour postprandial glucose of 110 to 140 milligrams per 100 ml and 2-hour postprandial glucose of 100 to 120 milligrams per deciliter. Also, concomitant with that is lifestyle changes is very important. Insulin preferred medication for treating hyperglycemia in GDM and metformin and glyburide should not be used as first line agents as both cross the placenta to the fetus. Hyperhomocystinemia in pregnancy is also a very important thing to look at. It is an amino acid role in key metabolic processes including the methylation and sulfuration pathways. Blood concentrations of homocysteine are determined by various dietary factors including folic acid and B12 by alteration in the physiology such as renal impairment and by variation in the activity of enzymes in the various pathways as a result of genetic polymorphisms. Hyperhomocystinemia is tied to vascular disease. In normal pregnancy, homocysteine concentrations are low. The mechanisms responsible for this fall is that the glomerular filtration rate that accompanies pregnancy is increased. Increase in plasma volume is associated with hemodilution and increased uptake of homocysteine by the fetus. So, high levels of homocysteine can result from acquired factors like deficiency of vitamin B6 and 12 and folic acid, high meat diet, and smoking, and others. The genetic factors could be an abnormality in methionine homocysteine metabolism, and hyperhomocystinemia is associated with premature atherosclerosis and venous thromboembolism. Hyperhomocystinemia is one of the risk factors for recurrent fetal loss, intrauterine fetal death, thromboembolic disease in pregnancy, neural tube defects, and congenital cardiac malformation in infants, and other placental diseases like preeclampsia, placental abruption, intrauterine growth restrictions. So the management here would be diets rich in fresh fruit and vegetables as well as vitamin supplements, particularly folic acid, have been associated to lower homocysteine levels. Treatment of hyperhomocystinemia is with folic acid and B12 and decreases homocysteine levels significantly. Let's look at the renal complications in pregnancy, which is also very important because this has the pregnancy as a stress factor also affects the kidney, which has to actually excrete that extra plasma volume with all the toxic substances, and therefore the renal factors also have to be looked at. What would be the physiological changes in pregnancy in the kidney is that it is because of this physiological changes that the kidney has to actually function even more efficiently, and that would be the increased blood volume, cardiac output, levels of nitric oxide and relaxin, relative resistance to vasoconstrictors, the glomerular filtration rate increasing by 50%, urine protein excretion, as well as the Th2 phenotype and the circulation of the tregs. It's decreased systemic vascular resistance, systemic blood pressures, and the serum creatinine. So, renal changes in normal pregnancy in this tabular column, it is a busy slide. The size increases to by 1 or to 1.5 centimeters, and the kidney volume increases to almost 30%. Sometimes a little bit of hydronephrosis is also physiological dilatation of the kidney, and the kidney above the baseline. The GFR is around 150 to 200 ml per minute, and the serum creatinine falls to zero point 0.4 to 5, zero point 0.5. The uric acid also falls to 2 to 3 milligrams per deciliter. The blood urea nitrogen falls to 8 to 10 milligrams per deciliter, and the sodium, there is a mild hyponatremia, and the osmolality falls to a new osmotic set point of about 270 milliosmoles per kg. So, very important to understand that when you read the reports of a pregnant woman, you must understand the new standards for pregnant women vis-a-vis a person who's not pregnant. Now, pregnancy-related acute kidney injury can be, the various causes can be severe sepsis from septic abortions, hypertensive disorders of pregnancy, hemorrhage, thrombotic microangiopathy, heart failure, acute fatty liver of pregnancy, postpartum hemorrhage, hyperemesis gravidarum, uh, and pyelonephritis and lupus nephritis as well. Now, let's look at the next case, that is case 3. A 42-year-old woman, poorly controlled hypertension, presented at 30 weeks of gestation with vaginal bleeding and abdominal cramping, had intrauterine fetal demise and placental abruption. Her hemoglobin was only 9.5 milligrams per deciliter, and her platelet count was 75. Serum creatinine level of 1.8 and an elevated liver enzyme. Low fibrinogen levels of 110 and a prolonged protamine consistent with disseminated intravascular coagulation. What is the probable diagnosis? So, validated definition of pregnancy induced acute kidney infection is not yet established. Use of the risk injury failure, loss of kidney function, and end stage kidney disease classification in pregnant women needs further study. So, pregnancy is associated with a physiological increase in GFR by 50 to 80% and an increase in plasma volume. So, together, these cause a fall in serum creatinine, which can mask a mild acute kidney infection. Serum creatinine level is lower in pregnancy due to hyperfiltration. So, increased in serum creatinine level to zero point 0.3, consistent with stage 1 in the AK1 network, may represent an significant kidney injury. Smaller increases in serum creatinine of less than zero point 0.3 milligrams per deciliter may be more sensitive for picking up early injury. Serum creatinine levels should be interpreted with the context of each clinical scenario. An increase in serum creatinine levels by zero point 0.2 milligrams in a woman with a new onset hypertension and low platelet count concerning for HELP syndrome or atypical hemolytic uremic syndrome likely indicates kidney injury. A close follow-up of a serial serum creatinine values and relevant serologic tests results required. This is very important. So therefore, using serum creatinine to diagnose acute kidney injury in pregnancy, this would be the way you will manage. So she had acute kidney injury and an elevated serum creatinine level, possibly due to severe preeclampsia. Help will be hemolysis, elevated liver enzyme test results, low platelet count syndrome. A severe form of preeclampsia is commonly associated with kidney injury. So, therefore, how do we manage such a case? Identification of the underlying source of injury, volume resuscitation, prevention of further injury, timely initiation of renal replacement therapy, prompt delivery of the fetus if required, steroids and immunosuppressive therapy for biopsy proven cases of glomerulonephritis. So, what would be our take home message today is that let us look at both the renal as well as the diabetic complications or the cardiometabolic complications and make sure that you understand the pathophysiology of both and make sure that you treat these people appropriately and timely manner so that these people can have a safe pregnancy throughout, that both the mother and the baby are healthy at the end. That is the message that I would like to put across to you. And thank you for a patient hearing. Thank you.
Thank you, ma'am. Thank you for this elaborated lecture, ma'am. Uh, and ma'am, we have a few queries. I mean, although you have explained beautifully, but still, ma'am, we have few queries. So, with your permission, can we take, ma'am, few queries?
Yes,
Yeah. Thank you, ma'am.
sure.
So, ma'am, first is up to what extent we can go for trial of vaginal delivery in renal complicated cases?
I think, can I stop this slide share?
Yes, ma'am. Manmeet?
Hmm?
Yes, ma'am. Yes, ma'am. You can now stop sharing.
Yeah, so I can go back to this. Yeah, fine.
Yes,
I
ma'am.
think particularly with renal complications, one would have to look at a very low threshold for vaginal delivery.
Ma'am, your voice is breaking. It's not coming. Ma'am, can you hear me?
She got disconnected, I think.
Ma'am, disconnect. Okay.
Can you hear me here?
Hi, ma'am. Ma'am, can you hear me?
Can you hear me?
Yes, ma'am. Yes, ma'am. Now it's audible, ma'am. So, okay, ma'am. Shall we continue, ma'am? Ma'am, can you hear me?
Just 1 minute, 1 minute.
Yes, ma'am.
Mm-hmm. 1 minute. Can you hear me?
Yes, ma'am. Yes, ma'am. Very well.
I can't hear you.
Okay. Manmeet, can you help, ma'am?
Ma'am,
Manmeet, am I
Can you
audible to
hear me?
you?
yeah, you
Yes,
are
ma'am.
audible.
Yes, ma'am. We can hear
Steven?
you, ma'am.
Yeah, we can hear you, ma'am. Ma'am, are
Arvind?
you on the mobile? Can you use the headphones? Try that.
Arvind is on speaker. Can you?
Ma'am, can you
I don't know
use
what's happened
headphone,
there. I
ma'am?
think there's some problem with the net here.
Okay. Ma'am, can you use headphones?
Yeah, can you hear me?
Yes, ma'am. I can hear you, ma'am. Ma'am, am I audible to you?
Yeah, can you hear me?
Yeah,
Yes, ma'am. Yes, ma'am. Am I audible, ma'am?
yeah,
Okay. Okay.
yeah.
Thank you.
When you talk about hmm? Okay. See, when you talk about renal disease, I would be very scared because it depends upon the pre-existing values of the serum creatinine, and I would not like to go ahead and stress the kidneys too much, because if you look at a pregnant woman, she's already got 50% excess of fluid, and when you actually stress the kidneys too much and she lands up with a lot of problems post delivery, I would be a little worried. First and foremost, whether to allow her to go through pregnancy itself is a big problem, because what is the initial stage of those kidneys? If her creatinine level is in, say, for example, 1.2 or 2 creatinine, I would say okay. There are some people who come whose creatinine level is 3 or 4, then I think I would like to be a little wary of it, because I would like to see the quality of life that she will have. The second thing is, I would also like to see what is the reason why the creatinine level is high. Has it been because of, whether she has an abnormal kidney, whether she has only a single kidney, and if she's had some transplanted kidney, and therefore, one has to look at the history before one can actually say, just because she wants to have a transplant, then she should go ahead and have it. Because if she has a transplanted kidney, then I think she should go ahead and have it.
Share
I
again
guess ma'am
disconnected.
has again disconnected, right?
Yes, yes.
Oh, I'm sorry, Prashant, I'm having a problem.
Okay, ma'am, no issues, ma'am. I mean, I understand completely, ma'am. Because of this digital era, I mean, definitely we
I
cannot, I mean, rely completely on technology.
Absolutely. Yeah,
Yeah. So,
yeah.
ma'am, if with your permission, I mean, so, ma'am, we can end this session also if there are any issues.
No, no, we can go ahead. No problem. As
Okay.
long as the internet provides, I have no problem. I go ahead. I love it.
Okay. So,
Okay.
ma'am, then I will take, ma'am, one more question. How should we manage tachycardia in a normotensive pregnant woman, especially in third trimester, and maybe sometimes even in first trimester, and hemoglobin is normal?
Well, if the person has tachycardia, one has to look
Means
at other.
person wants to take ghabrahat. So, exact word he is using is a ghabrahat.
See, the thing is, even in situations where you talk of Gabrat, I think one has to know, why is she, fearful? Is there a problem at home, like some kind of a stress factor, or is there something that has been worrying her? That has to be addressed. One. Secondly, has there been any systemic things like, for example, a cough and a cold or fever or something like that, some systemic factor? So unless you remove the organic factors for this, or is there only a sinus tachycardia, or is there a silent thyroid factor? So one has to look at all this rather than just to dismiss this, tachycardia as saying that it's only gabrahat, because we have to make sure that the underlying factors are all cleared before we just say, oh, it's nothing, don't worry, just take a sleeping tablet and everything will be all right. I would be very clear that I will not go and give a tablet to a pregnant woman unless it's absolutely required. I would like to make sure that when she comes and says something, I will take it very seriously and I will go into the depths of it. It could be just that there may have been some kind of a marital problem, or there may have been a problem with some kind of death in the family, or some kind of a stress factor. So she won't come out with it the first time, but you have to talk to her. And a patient hearing to her problem, sometimes, the pulse rate comes down. In other times, some you'll find that the sinus tachycardia, just a little bit of a vagal massage at the neck, that itself will bring it down. But if you find that this pulse rate, if it is like 80 or 90, please check her temperature as well. Because usually, when you have this kind of high, the tachycardia, you must have some systemic, the same. A little bit of the blood picture also I would like to see. And you say that she's not got any anemia. I would like to see her total count. I would like to see her differential count. I'd like to see whether there has been some kind of a tuberculosis or something like that, because that also causes, this kind of this. Sometimes they are afebrile, but also they do have a tachycardia. So when I clear all this, then I reassure her, and then I tell her she may not have had sleep properly, or she may have had other things. So just a simple tachycardia will just go away, but after you have cleared all this.
Thank you, ma'am. Thank you. Ma'am, just one more question just came up. What should be the investigation for blighted ovum to know the cause? And what should be the investigation for missed abortion? Actually, there are 4, 5 questions in a single question, ma'am.
Yeah,
To
yeah.
find out
See,
reasons. Yeah.
correct. See, if it is a blighted ovum, the kind of investigations we would do with a blighted ovum is that most of these blighted ovums could be due to some kind of genetic causes. And these genetic causes would be more like either a chromosomal cause, or it could 60 to 70% will be some kind of chromosomal causes. And these are like either a trisomies, or it could be genetic causes. So one would not worry so much that is before the heartbeat or before a fetal pole has come in. But in such situations, if they've had repeatedly, the chromosomal tests of both the husband and wife have to be done. We'll have to see if there is any translocation, deletions, and any kind of other chromosomal abnormalities in the partners have to be checked out. The second thing is if both the partners are fine, but usually you will find some kind of a problem, structural anomalies in one of the partners. Now, if that happens and they've had about, say, 2 blighted ovums in a row, but if a person has had 1 blighted ovum and then they've had a missed abortion, the difference between a missed abortion and a blighted ovum is that the missed abortion could be that the heartbeat came and then the heartbeat was absent after the heartbeat came. Now, that is a little better sign, because once the heartbeat has come, that means the blood circulation has been established. So the chances of a chromosomal abnormality comes down steeply once the heartbeat has come. So in such a situation, the causes for a blighted ovum are slightly different compared to a missed abortion. So in a missed abortion, it also could be the fact that there could be genetic abnormalities there. I'm not saying no, but it also could be due to some kind of thrombosis. It could be a kind of anatomical factors. It could be thrombotic factors. It also could be due to chromosomal factors. So one will have to investigate what could be the factors over there. And unless investigating them properly, don't tell them get pregnant again and come and see me. This is the common question that everyone says. It is absolutely mentally devastating for a woman to get pregnant and have a missed abortion. So for a doctor to tell her, Array, next time get pregnant, we'll manage you better. So why did you not manage her now? So she has not done any mistake. So first thing is find out the cause first before you tell her to get pregnant again and come. Because there may be some correctable causes, like for example, infection inside the uterus. Infections have to be corrected. If there have been polyps or fibroids inside the uterus, that also has to be corrected. So first clear up that infection or tumors, or there is any kind of thrombotic episodes inside. So you need to clear up the scars inside the uterus or repeated DNCs or whatever it is. Do a hysteroscopy, find out whether there are any problems there, adhesions there. Then clear that in adhesions appropriately. Maybe even vaginal probiotics put inside also will help. And then you go ahead and ask her to try. Otherwise, repeatedly getting her pregnant and then subjecting her to miscarriages is not the answer.
Thank you, ma'am. I guess that was the end of our session. And first of all, I would like to say, ma'am, thank you to you on behalf of Mankind Pharma for giving us this opportunity to listen to you. And definitely our audience, I mean, definitely they are fan of yours, ma'am. As I can see, there are comments they want to hear, I mean, their idol and all. So definitely they are right also, because you have actually changed the this infertility scenario, I mean, in India. So thank you, ma'am, for sharing your views of this regarding cardiac and renal complications in pregnancy. So thank you once again, ma'am. Thank you so much.
Thank you. Thank you very much. Thanks. Bye.
Bye.